Welcome everyone to the Qatar Association lecture, COVID-19 vaccines, debunking the myths. So today we have Dr. Pooja Dassan, who is going to host, who's going to interview Dr. Gurjinder Sandhu, and also, right, so if I can hand it over to you, Dr. Dassan.
Thank you. So welcome everyone, and thank you to the Patois Association for inviting us to deliver this webinar, which I think is hugely topical at the moment. As has already been alluded to, so my name is Pooja Dassan and I'm actually a neurologist. I work at Ealing Hospital and also at Imperial Healthcare Trust. With me today I've got Dr. Harmandeep Singh, who's a acute medic and also COVID strategy lead at Ealing Hospital as well, and Dr. Gurjinder Sandhu, who's an infectious diseases consultant and was with us at Ealing Hospital and recently moved to King's College Hospital. So I hope between us we'll be able to debunk the myths, so to speak. Now, by way of background, of course, we've all been hearing about COVID for the last year. But what raised increased alarm and concern was at the end of last year, when we found out that there was this new strain. And the government tells us, and the scientists tell us, that they'd known about it since September, and that it probably originated in the Kent area, but then it began to spread nationally and also outside of the UK now. And what worries us about this strain is that it is increasingly transmissible. So that means you're much more likely to catch it. And therefore, this time round, sadly, many of us do know people that have contracted COVID, and maybe we didn't so much the first wave. And certainly we're seeing that effect in the hospital, which we'll hear about. In addition to it being increasingly transmissible, there is also evidence to suggest that it is also more fatal. And that's why we need to be more vigilant, and we need to continue to take all the precautions that we did in the first wave and not stop now, not develop fatigue with that at all. We also hear about other strains. So it's not only our strain in the UK, but we hear about strains from Brazil, South Africa, and that raises concern as to whether we're going to see the end of it. But thankfully, the vaccinations are coming through, and that is going to be our light at the end of the tunnel. So to start off, I wanted to start with you, Harman, and I wanted you to tell us, in this second wave, what differences are there between this wave and the first wave? I want you to cover in terms of numbers coming into hospital that you've seen on the front line, real world problems here. I want you to cover the demographics of these patients. Are they young? Are they old? What sort of age groups are we seeing? And I also want you to cover what sort of armory we have, what sort of medicines we have this time round that might be able to help us that we might not have had in the first wave.
So thank you, Pooja, for letting me start with this. So as you all know, with the wave one, as it started, it hit us quite all of a sudden within a span of a week to a few days. And the hospitals were full of COVID patients. Government had a message, stay home, keep NHS protected. And people just decided not to come into hospital. Well, those who came in with COVID. And what we were seeing more at that time was that we were having more elderly patients being admitted and requiring oxygen. Of the total who were admitted, around 13% of those required to go on some special breathing machines, which includes, you might have heard about CPAP and going into intensive care unit. And that was wave one. But this time around, with the second wave, it is actually much worse than what we had seen in wave one. What we are seeing this time is also that it is not just the elderly patients who are being admitted. It ranges from as young as 23-year-olds going up to as old as 100-year-olds being admitted. What also we are seeing is that the severity of disease or people who are coming in much worse than what we were seeing in wave one. More people are requiring to go on these special breathing machines, including CPAP and intensive care unit. And as I quoted the number, 13% in wave one has unfortunately gone up to 25% in wave two. This time we are seeing a lot of young, fit, healthy people who do not have any other problems or health issues or are not on any medications, coming in requiring loads of oxygen and actually struggling to get better and requiring a increased length of stay in hospital to improve. Unfortunately, we are seeing more deaths as well, and that deaths are not limited to older people. They are also in young people, and that is despite them being on maximal medicine or therapy or equipment which we can provide. We had, in wave one, we had a luxury of having a lot of doctors and nurses being redeployed from various areas. But this time around, unfortunately, we don't have that because a lot of services are still running within the NHS. The numbers are much worse than what it was in the past. Pre-COVID, we were trying to maintain a junior doctor, which includes the SHOs and the F1s and registrars ratio of 1:6. So 1 doctor per 6 patients. And I'm not talking about the consultants. This time around, it has gone up to 1:18. So 1 doctor for 18 patients. And if you think about redeployment, as you see, if you let's take an example. If you're a zookeeper and you all your life you looked after penguins, and suddenly you're asked all of that, okay, now you need to look after the tigers. Not that you'll be bad at that, but you're not completely comfortable with that. And that's how our staff is, that being pulled from left, right, and center, asked to work in the middle of night to go on intensive care because they need more people to help them, is not ideal. And that's the situation. Ealing Hospital particularly has been badly hit. Being in middle of Southall, we have a diverse population and a complete diverse demographics. A lot of house sharing, a lot of people who unfortunately have to rely upon work to feed themselves, and that work cannot be done at home because either they are cab drivers or they're builders or they're working at Heathrow Airport or in the off-license shops or kebab shops and things like that. So they have to go to work to feed their family and themselves. And unfortunately, that has led to increase in the number of patients we are seeing. We are also being hit by house sharing because a lot of our patients coming in, there are like 10 families living in the same house, sharing the same kitchen, which had made the isolation a bit difficult for them. So it's not a good situation. It's the wave 2 has, as the newspaper says, it's really hit us bad.
Thank you, Harman. And would you comment on the medicines that we have available this time? Do you think they have helped tackling the numbers this wave? I appreciate they're high because more people have had it, but do you think they have helped in any way to combat it?
Yes, they have, certainly have. In wave 1, we were going by the evidence which was coming out on day-by-day basis, and the guidelines were being changed literally on a weekly basis to add in more drugs. Quite a few came out of recovery trial. We now have steroids like dexamethasone, we have remdesivir, and another one which is still not licensed but in recovery trial, tocilizumab. So there are a few drugs which we are using. All the patients who are being admitted to hospital are getting them. With that, what we are seeing is that some of them are certainly getting better. The mortality is expected to be less. And they do work if given on time. But what we are also seeing is patients are not coming into hospital in time. They are delaying it by so much that when they come into hospital, they are in quite an advanced stage of their disease, where despite us having all these medications, they may or may not be that helpful as it would have been if they had come in earlier to hospital. And I must say that there is, we've heard a lot about rationing and stuff. There is absolutely no rationing going on, and there is no deprivation for any sort of a patient, which we do in terms of any treatment plans or any equipment. We're not lacking equipment at all. We have plenty of equipment. It is the manpower which we do lack in, but the medications are making a difference.
Thank you. So it sounds like a Herculean effort from everyone at the front line. Can you tell us what morale is like, fatigue levels are like? How are people continuing?
People are stretched, people are tired, exhausted. Nurses, HCAs, to porters, to doctors, everybody's working double or triple than what they should be. 7 days a week, NHS is functioning. Nobody has taken any break or any leave. And I think within the hospital, people have a passion, and people have a passion to treat, and they will do their work quite religiously, despite whatever their personal circumstances are. What has an impact on the morale or their psychological sort of status is when they go out and see people not obeying the rules, or when a patient's relatives tells you that we are trying to kill patients and things like that. So that is the most demoralizing thing, I think. When we are providing the best of the care we can to best of our abilities, then to have negative comments come across from anyone, it just hurts essentially, and it takes away the whole purpose. So the morale, still we are trying to do our best, and I think people will continue to.
Thank you. Thank you. Now, Gurjinder, I'd like to turn to you. The premise of this webinar is, I suppose, vaccinations, but it was important we heard the impact that the virus is continuing to have nationally. Vaccines have arrived since the end of last year in droves, it feels, they're coming through thick and fast, which is amazing. And there's been a great global effort to achieve this. Could you talk to us, because many people have fears, how could these vaccines have been developed so quickly? Normally it takes years. Have they jumped through all the right hoops? Have they been properly regulated? Are they safe?
Okay, firstly, I'd like to say thank you to the Pathara Society for organising this. Our spiritual leaders have never shied away from infectious diseases or shied away from challenges. Shri Guru Har Krishan Ji passed away fighting smallpox. He didn't shy away from it. Jesus Christ looked after patients with leprosy. He didn't shy away from it. And what we know now is that with smallpox vaccination, we were able to eradicate the virus that took away the life of our child Guru. And when I talked to my parents and asked them when they got their smallpox vaccination, they think it was during the time of the partition between India and Pakistan, which in some respects is understandable, because that's when we had large groups of people in refugee camps and we had large groups of people at risk of smallpox. So if the technology and the infrastructure was present at that time to eradicate smallpox from the planet, then I truly do believe that in 2021, the technology and infrastructure is present to eradicate, or at least start changing the impact COVID-19 is having on our lives. This has been a global scientific effort. Ever since the virus was first isolated, the Chinese scientists shared the genetic data of that virus with the whole of the world's scientific community, knowing that the race was on to find a vaccine to put this to an end. And I don't think in my career I've ever seen scientific collaboration or scientific work to this level before. So I don't think there's been any loops that have been jumped through a scientific point of view. A lot of the technology that we hear about, messenger RNA technology for vaccinations, is technology that various pharmaceutical companies had been working on before. A lot of the new viruses that were mentioned this week, Novavax and the Johnson & Johnson, they've had technology and vectors to be putting genetic material from different viruses such as Ebola and Zika. So a lot of science was already in place. The genetic data was shared early globally. And the only place where I would say that loops may have been cut is the red tape. That governments around the world had just cut through the red tape so that people could go through and get these vaccinations. The scientific papers have been published in good standing peer-reviewed publications such as the Lancet and the New England Journal of Medicine. And I do believe very strongly that our only way out now is vaccination, as it has been with smallpox and polio in the past.
Thank you. There are also many concerns that particularly vulnerable people or elderly population, they haven't been included in these trials as much. I mean, perhaps they didn't want to volunteer, perhaps they didn't feel safe to volunteer for trials. So how can we say then that these vaccinations should be rolled out to them? Are they safe in that population?
Yeah, so absolutely. And I think a lot of this comes from the Oxford AstraZeneca trial, where unfortunately they weren't able to recruit very many elderly people or people over the age of 55 into that trial. We've got to remember that this time a lot of elderly people were shielding a lot of elderly people were frightened, and it tended to be younger healthcare professionals who were volunteering to go into studies. A lot of the other global studies did have people from Brazil and South Africa, which did include older patients. And we know from our past experience with influenza vaccination that specifically targets the elderly, that those vaccines are efficacious in the elderly. So I do agree that as far as the scientific data goes, for one of the papers, we did not have many elderly recruited, but since then, we have had many elderly who have had their vaccinations, and we are starting to see that A, they did not get significant side effects, and B, as time goes on, we're starting to see that protection effect in that group.
That's very reassuring, thank you. Coming back to you now, Harman, there's been a lot of data that's come out through national surveys that people of Black, Asian and ethnic minorities are reluctant to take up the vaccine. And there are, of course, several reasons for this, and I want to try and discuss that with you. Now, it is obviously the Black, Asian and ethnic minorities that are more at risk of this virus and at more risk of getting unwell with the virus. So it concerns us more than ever that this is the particular population that are so at risk and also more likely to reject it. It's important to stress that these aren't the same ones that are so-called anti-vaxxers. These are people that have usually got the vaccinations previously for flu, etc., and ones that have vaccinated their children even. But there is this vaccine hesitancy because of the pace at which this vaccine has come out, which we've discussed, but equally some of the myths that are being spread in our communities. Now, we are in the world of social media, and we didn't have these issues before, but it seems that that might be one of the issues. Could you discuss that for me, Harman?
Yeah, so as you rightly said, that the social media, I think, is the biggest culprit, and it's a fear mongering amongst our community and people, because when they get information passed on to them in a native language, which they understand better than English, then they tend to believe that better. And the other thing is, when you start getting information, if you have 100:1 ratio, like 100 messages sent across which are against a vaccine and one message which is in favor of vaccine, you are more likely to believe the 100 which are probably against the vaccine than believing the one for vaccine. If we had this level of social media misinformation spread out at the times of smallpox or polio, we would never have been able to get rid of this. It was because people believed in science, whatever was available at that time. People believed in what was being offered to them by the healthcare professionals. And that's how we managed to eradicate smallpox. That's how we managed to almost are at verge of ending polio now as well. So these social media messages is the biggest threat. And sometimes it's just that our community just needs a bit of a hand holding, that somebody to tell them that actually this is fine, this is safe. And as Dr. Sandhu has just mentioned, that these are all scientific evidence-based vaccines which have been rolled out. So the social media remains the biggest issue. Now, within that, I've seen so many of myths which have come across. And which have been in the media, which have unfortunately been endorsed by celebrities, some of the celebrities as well, some of the sports stars and TV and film stars. Now, keeping in mind, those film stars are popular, yes. They've got a lot of fan following, which goes in millions, yes, but they are not scientists. They are not doctors. They do not have any scientific degrees to actually validate a vaccine or a drug, or to reject that. What they are representing on social media are their own personal views. And what science and what NHS and what we are trying to do here is all evidence-based, which is peer-reviewed and published in the journals. So that's the thing. And if we discuss about the myths which have come across, I've been sent a lot of messages, which then I have try to reply as much as I can to try and clear some doubts. And I'm sure people would have got the same. One of them is about 5G, that the coronavirus is being spread by 5G and the vaccines it shouldn't be. And I think that's one of the most bizarre ones which would have come across. And I did come across a structure of coronavirus vaccine, comparing that to a 5G tower. And I'm not too certain how many people actually can or understand that structure. I can't, personally. Even if somebody shows me a coronavirus vaccine structure, I wouldn't know whether it is or not. So I don't know how and why people are believing in that. And then there was this thing about people being tracked by microchips, and Bill Gates being involved in that, quite a high on internet. And if you think about it, we've got these mobile phones. I think they are the best trackers in the world. Why do we need to have a chip injected within ourselves to track if government was to do that? So I think that these are just, people are just spreading this misinformation. Then there was this information about infertility, that vaccines can be related to infertility. I'm sure Dr. Sandhu will want to talk about that in a bit more detail. But that's again something which came out of nowhere, that it is linked to infertility. Then I had heard more about these vaccines, again, the safety ones, which was the biggest one, which we have already discussed. That Dr. Sandhu has just mentioned that that's one of those. And then I come across a lot of questions about which vaccine is better than other. Oh, I don't want Pfizer, I want Oxford. I don't want Oxford, I want Pfizer, and things like that. And then you're like, you know what, these are all, MHRA has approved all these vaccines based upon their efficacy and safety, and there is no such thing as one is better than the other. What they're trying to do is they're trying to build up body's defenses against a coronavirus infection. And then there was this thing about whether it is vegetarian, whether it is halal, whether it has got animal products in it, and how it is built. And I'm sure, again, we'll discuss that in a bit more detail with Dr. Sandhu as well. But all I can say is that NHS has released a statement that the final product does not have any animal products in it. The final vaccine which comes up, and we will discuss that in a little bit more detail a bit later. Then I had my own father actually ask me, because he had multiple stents put in over the last 20 years, and a lot of his colleagues in India were telling him not to take the vaccine while I was pushing for it, that he should go and get the vaccine done. And he was being told, oh, if you have got stents and if you get a vaccine, then the stents can block off, or stents, even one of them said the stent can fall out. So I was actually laughing. I was like, well, I don't know where these things are coming from. If you have got stents, or if you've got heart failure, or if you've got underlying diabetes, high blood pressure, or any lung problem, or any autoimmune disease, like rheumatoid arthritis or something, then you are more likely to be at high risk from coronavirus than anyone else. And you should get it first rather than anyone else, to make sure that you are safe, rather than getting a vaccine. And if you ask me personally, the choice is pretty straightforward. You've got a disease which has got a significant risk of death. You can potentially die of it. You've got a vaccine which can potentially save you. Which one do you want? So the answer is pretty straightforward.
Thank you, Harman. I completely agree. I think the biggest threat to our society is the misinformation, in all honesty, more than the corona itself. And it's the misinformation virus that we're all actually more worried about, particularly from the health and science viewpoint. I wanted to come back to Gurjinder, and actually, I know you've had a look, being an infectious diseases consultant, at those actual research papers. Could we just debunk some of that stuff about animal products in these vaccines? Is there any concern at all for those people that want to avoid it for that reason?
So there are different technologies that have been used by the different vaccine manufacturers. And I can see there's some chat about messenger RNA and other bits, which I can try to address here as well. The most traditional way of a vaccine can't replicate outside a cell. So vaccines, if you want to produce virus, then you need a cell in which to replicate it if you want to produce the whole virus. And that is where chicken eggs and fertilized chicken eggs are used for the manufacturing process, specifically of the AstraZeneca Oxford virus. So I think this is where some people do feel that they might run into a particular sort of religious difficulties. Now, at the beginning of this pandemic, as a Sikh bearded man with a turban, I was on the front line as an infectious diseases doctor, and I did feel that the PPE was not going to be as good if I had my full length beard. And for the first time in my life, I shaved my beard. And it was a very difficult decision at the time, but it is not one I regret, because at that time I knew I was doing it for my safety, my family's safety, and my patients' safety as well. and I could reconcile with it. And since then, we have been able to get hoods. I was very grateful that Harman helped us to get hoods so that we were in a safer position.
Gurjinder, did you just want to explain why it was that the beard would mean that you weren't safe working in the hospital?
So personal protective equipment, it effectively involves different types of masks. Harman was talking about non-invasive ventilation, which can generate aerosols. So you need a very tight-fitting mask to stop those aerosols from coming in. And if you have a beard, if you have a long beard, then those masks don't work. And that's why I made that decision at that time. And again, I can see that people may have views about the use of chicken eggs in the manufacturing of virus, but it is the same technology that has been used in the past for measles, mumps, rubella vaccinations, rabies vaccinations, and other vaccinations in the past as well. And what I would say to those people is, even if your views are extremely strong, then there are alternatives that we can turn to, which then gets us onto the messenger RNA sort of viruses. I can see in the chat that lots of people are quite nervous about this because it is new technology as far as we're concerned in terms of it coming out into the world and being used for the first time. But messenger RNA technology is technology that has been used scientifically and has been studied for quite a long time. And a lot of these scientific pharmaceutical organizations that were able to produce this vaccine so quickly had been working on previous vaccinations such as Zika and Ebola using the same technology. The messenger RNA only stays in the body for about 3 days. So messenger RNA is effectively a code that allows your cells to produce that protein. So where is that messenger RNA injected? It's injected into the arm, into the muscles. So that messenger RNA is taken up by muscle cells only. It doesn't go beyond this area. And those muscle cells then produce that protein. And then the immune system develops an attack against that. What we've got to remember about vaccinations as opposed to medications, I think someone earlier on had mentioned thalidomide in the chat as well, is that we have been created with a phenomenal army. Our immune system is an army that is ready to fight any infection that it faces. And what we are doing with vaccination is priming the army. We are teaching the army before that virus arrives. And we are taking one component of that virus, a small protein or a small piece of messenger RNA, to actually teach our immune system. So it's more about training. Now, you think about the old takeaway that you've just eaten, that you've just heaten up, and straight away the body rejects it. It starts vomiting, you start having diarrhea. There are so many ways in which our body will start defending itself against different forms of infection. But what vaccination does is training. It's almost a school. It's training our body to be ready for that virus. And that army then goes to sleep, and the moment the virus arrives, it is ready to fight that battle, and it can stop that infectious agent from getting into the body, let alone causing any harm in the body.
Thank you. So I think it's important to recognize that even after you've had both doses of the vaccine, you may still end up getting the COVID-19 infection, but because your body has already done all that training, hopefully you won't have any symptoms from it at all. And if you do, it'll be very mild.
And that is a very key feature of absolutely all of those studies that have been done. So all of the studies have shown that effectively the protection against severe infection. So when Harman talks about 25% of those patients going on to non-invasive ventilation or needing intensive care, that is what vaccine is protecting you against.
Thank you. So we've heard from the government that this week that more than 100,000 people in the UK died from COVID-19. And we know that there's 2 million fatality rates across the globe from COVID-19. And the government decided to take a strategy that we all got our first dose according to the guidance and that the JCVI committee decided. But what about the second dose? That's been delayed, and that's a bit controversial. What are your views on the fact that our second doses have been delayed until the most vulnerable group have all received their first?
So this is where I would turn to Guru Nanak and Guru Nanak's concept of socialism and Guru Nanak's concept of the greater good, the bigger good coming first before the individual good. So yes, we can argue that as an individual, if we got both of our doses of vaccination, we will be better off. But as a society, what we're looking for is herd immunity. And what we need, or what we think we need with COVID-19 is for at least 50 to 80% of people to be vaccinated for us to achieve that herd immunity. So I do agree with the principle that whilst we've got limited amount of vaccine, that we should be looking to vaccinate more people with their first dose than have individuals get their second dose. Interestingly, the WHO has gone one step further with Guru Nanak's concept of socialism and saying, listen, the UK, you're rushing ahead and you're getting to this point and it's great and it's really good for you. But what about all of those other countries on the planet that haven't even started their vaccination process? And shouldn't we all be thinking about herd immunity from a global point of view, not even from a national point of view and an individual point of view? So I think this is where we must start thinking about the greater good as opposed to the individual good.
Yeah, that's right. And this vaccine nationalism that's come about is not a very collaborative way of combating this disease, entirely so. We've got a lot of questions asking about what cohort of patients or what groups of patients should really not take the vaccine. Is there a particular cohort that, particularly if they've had perhaps adverse anaphylactic reactions to certain vaccinations in the past, that perhaps shouldn't be receiving it this time round?
So firstly, again, anaphylaxis was, I don't think, I'm just got to make sure if I remember correctly, but out of definitely the New England Journal paper and the Lancet paper, anaphylaxis was not a major feature in terms of side effects. Anaphylaxis is a risk with any vaccination, with any medication. And I do believe that GP practices are making decisions about which vaccine to give, depending on how severe the allergy is. So for example, if you do have a confirmed egg allergy, then you should not really be having the AstraZeneca virus that has been produced in chicken eggs. But these are not live vaccines. It is the live vaccines where we tend to say that people whose immune systems are weak should not have them. A lot of the time where we have contraindications, and obviously, Pooja, this is an area that you have a lot of interest in, is where we don't necessarily have scientific data, for example, in pregnancy. But again, there is no reason why these vaccines couldn't be used in pregnancy. And actually in influenza, we often find that pregnant women would become one of the sicker groups and one of the groups that we would be targeting for vaccination.
That's right. I would like to comment on the back of that because there has been a lot of controversy about whether pregnant women or breastfeeding women should receive the vaccine. And similarly, as a result of the fact that a lot of the elderly were shielding during the time that these trials were going on, similarly, pregnant women were shielding. And for our audience, I want to explain to them how pregnancy is a state where your immune system is already suppressed. And you've got to imagine it sort of has to be. Your immune system can't be working at full whack because you've got a baby, and otherwise the mother would reject the baby. So your immune system is always suppressed in pregnancy. And therefore, you're left with, and this is similar to what Harman said, you're left with a woman with a suppressed immune system, potentially at threat of catching COVID-19. And we know from the data that pregnant women, particularly in their third trimester, that's at the end of their pregnancy, are more likely to be hospitalized from their infections in their lungs. And therefore, the consequences can be graver. And yet, even though there isn't that much data, but we're getting new real world data as these vaccines are rolled out, there has been no evidence to suggest that vaccination can be harmful in pregnant women. So I think you have to weigh up those odds, and it is therefore now being offered to all pregnant women who are in healthcare or social care, but equally to pregnant women who have other medical problems that might put them at increased risk. So what we say is vulnerable patients. Harman, did you want to say something?
I was just going to add on to the DNA thing. These vaccines, as Dr. Sandhu has just mentioned, that the Pfizer and the Moderna vaccine are mRNA vaccines, while the Oxford AstraZeneca one is a DNA vaccine. There is a lot of myths going on around whether it can alter the DNA, or your DNA, if you get the vaccine. So I saw quite a few messages around that as well. And that's completely wrong. These are the types of vaccine, the way they have been developed. And it's not that it can alter your DNA. If we had that much of ability of modifying your genetic code in adults, then by all means, we would have got rid of cardiovascular diseases and diabetes and hypertension as well by just altering your DNA codes within that. So that is completely wrong. And I think if people believe that, they just need to trust it, that it cannot alter. No drug can actually alter your DNA code as it is, or genetic code. So that's a kind of, again, another misinformation which is being spread out.
Thank you. And Harman, could you just answer for us, people that have had their first vaccine, because there's a lot to do with behavioral sciences when you're dealing with a pandemic and you're rolling out treatments. And this was a concern that the government had initially, that they went into lockdown initially. This was one of their reasons for delaying lockdown, was how long could people really shut themselves in their houses for? So now we've got this, what's currently happened is we're getting the first dose, and a lot of people are starting to just be a bit more relaxed. Do you think there's any place for that?
No, absolutely not. I don't think we are at a stage yet, because if you got first vaccine, as Dr. Sandhu mentioned, that you are somewhat protected, not fully protected, but somewhat protected from a severe disease. But that doesn't stop you from spreading the virus to others. So the vaccine, if you that'll be, I think, as somebody who is not following the rules because they had first dose of vaccine or had COVID-19 infection and have recovered, are being extremely selfish, because they may not get that, they might be safe at that particular point, or they think they might be safe, but they can spread the virus to others who probably might be more susceptible at that stage. So they're not 100% protected after the first dose, and thereby everybody should strictly follow the rules, maintain space 2 meters apart, hand washing and face masks, and if they are shielding, they should continue to stay in shielding till we've had a herd immunity, as we just discussed, and everybody's had their doses.
Thank you. Gurjinder, coming back to you, and this is in line with some of the questions being asked as well. If you've already had COVID, say in the first wave, should you receive the vaccine? Do you need the vaccine? Could you start there?
Yeah, I mean, it was interesting, and I've seen a couple of other questions that also sort of strongly feel that frontline NHS staff as well should get second doses. So I had COVID, Harman had COVID, we all had COVID in the first wave, and I was thinking to myself, I wouldn't necessarily be joining the front of the vaccination queue, because, you know, I was feeling that the immunity I've had from having had the virus itself is good. It should be good enough. But that said, we are the front line, we are the workforce, and I think that we have sadly watched our colleagues die. And we have seen across the NHS, again, affecting Black and minority ethnic doctors and nurses and porters and security guards. So the comment where someone is saying that NHS staff and frontline staff should get their second dose, I would agree with that, because we are very much so there on the front line dealing with this frightening illness. And if we talk about our immune system having soldiers and having an army, then NHS staff do represent that army within this country that are fighting this virus. You can argue that the immunity you have had from the vaccination itself is protective, and a lot of the trials excluded people who had the virus itself. There's another question that has come up a few times, which is, does the vaccine prevent me from catching it again? So far, the scientific community is looking to see whether the new mutations that have come about in these new strains, and you've mentioned the UK, the South American, and the South African strains, whether the antibodies that are used to neutralize can still affect those strains. So imagine that the vaccine is producing an antibody and a new strain has an antigen. And what the scientists are now doing is seeing, does that antibody still protect against this if it looks a little bit different? And so far, the data is showing, certainly with the Pfizer vaccine, that those antibodies are protecting against the new variants. And that work needs to continue to happen for us to understand. But certainly Public Health England are not necessarily seeing a rise or a massive rise in second infections.
Thank you.
Are protecting against the new variants. And that work needs to continue to happen for us to understand. But certainly Public Health England.
Not sure what happened there.
Sorry, yeah, carry on, please.
That's fine. Thank you, Gurjinder. And could you, there's another question that's come up. Could you comment on one vaccine versus the other? And obviously the two main ones that have been authorized by our regulators are the AstraZeneca one in the UK and the Pfizer vaccine. Further ones will, of course, follow, Moderna, etc. But these are the two that are currently available. Could you comment on the efficacy, that's how well they work, of one versus the other?
Yeah, so again, we are looking at two very different technologies. So the age-old technology of using chicken eggs to cultivate virus is what AstraZeneca did and Oxford did. And their efficacy came out at about 62%, which might sound really low, but actually with a lot of our seasonal influenza vaccines, we're having efficacy of between 50 and 60%. The messenger RNA vaccines seem to be doing better. You know, their efficacies are approaching the 95% for both Moderna and Pfizer. And the two new ones that were released, data released just to the media so far, not the scientific publication. And I would want to see the scientific publications before I comment further, would be Novavax and Johnson & Johnson, which are having 83% for Novavax and 66% for Johnson & Johnson. But the key with all of them, and the real key with all of them, is the prevention of severe infection. So we know that in all of those trials, people who had the vaccine did get COVID, but they did not get severe COVID. They did not get hospitalized COVID. And that's what we're aiming to protect against. Again, there was the comment about the messenger RNA, which I think still keeps coming up. Now, one of the big things about the messenger RNA vaccine was that it had to be stored at -80, or it starts losing its efficacy, kind of thing. Now, this piece of messenger RNA that is going to enter your body is just going to be used temporarily and disappears after 3 days. It's just not strong enough. It's not a very sort of viable piece of genetic material that will stay in your body and cause change forever. And the only change that it is capable of producing is producing one protein. And that protein will be produced only in that one area, and then it disappears from your body.
And could you remind us what the efficacy of the influenza vaccine is, so we can make a comparison?
So it varies from year to year, but it's often between 40 and 60%.
Okay, so everyone can get an understanding when they're comparing it to these new vaccines. Okay, we're getting some more questions. Harman, would you like to answer whether you know if children, particularly nursery age children, can be carriers of COVID? Has there been any evidence for that?
Not really. So the government has always maintained the stand, and the numbers which they have released, that the children under the age of 5 are less likely to carry the virus and spread it around. And that's why even when the lockdown happened and the schools were shut, the nurseries were allowed to remain open, although they were advised to maintain a bubble. And if one of the children or their parents get COVID infection, the whole bubble has to isolate for 10 days. Unfortunately, that has caused quite a significant trouble, even to myself. We've had at least 20 days worth of children staying at home because of the isolation. But even within those periods, it was not that a child had it. It was somebody else in their family who was found to be positive. So the government maintains a stand that so far no evidence in children under 5.
Thank you.
Although having said that, some children have had COVID infection, but so we haven't seen that much of severe disease in children, and they've tested positive because one of their family members had it positive. Only few cases were reported with multisystemic inflammatory response, which came out, but not like adults what we are seeing.
Okay, thank you. Gurjinder, back to you. Do you have any information with regards, a couple of questions have asked this, about the use of convalescent plasma? And that's taking plasma, so that's blood products from people that have had previous COVID-19 infection and therefore assuming have built up that, I love the analogy of the army of defense system. So they've already been trained to fight it, and then using those blood products in people that have now come in with the infection to try and boost that person's immunity.
So Harman earlier on mentioned the recovery trial. Ealing Hospital and King's College Hospital, so many hospitals have been involved with recovery. And actually recovery has shown that convalescent plasma has not helped. I suspect the reason for that is the army is coming too late. So we have patients on intensive care, we have patients where the virus has pretty much caused inflammation throughout the lungs, and we worry that the damage has been done or the battle has been fought so hard that bringing in the antibodies right at that stage is too late. And this is where vaccination gets your army ready before the enemy has even approached your body. So convalescent plasma didn't work in the recovery trial, I suspect because you're bringing the army in too late. The virus has already started to win the battle. Vaccination prepares your army before the enemy has even arrived.
Yeah, that makes entire sense, doesn't it? And then just one last question. People always worry about the side effects of vaccinations. With regards to any of these technologies, we're not seeing horrible side effects. We've all heard about that. What are the common side effects that we can expect to experience after our vaccination?
Sorry, Pooja, that broke down a little bit. Could you just repeat the question?
Sorry about that. I was just saying, in terms of common local side effects that we can expect to experience, and have there been any serious side effects that have been published?
So in terms of the side effects, so both myself and my father had very similar side effects, so we kind of compared notes on it. Having had COVID before, I expect that my army was ready for COVID a second time. So the day I had the vaccination, I took to my bed for 24 hours with muscle aches and fevers and shivers, and my arm was hurting quite a lot. And that was literally the first 24 hours. But I saw that as a good sign, because I saw that as my army was ready. My army saw the tiniest bit of messenger RNA from this virus, and it mounted an almighty battle against it. Dad had a similar response in the sense that he had a fever and he had arm ache and he felt very tired, and he took to his bed for that day as well. Those have been the sort of two sort of major those have been the side effects that I think the majority of people would experience, kind of thing.
When I had vaccine, I think I came back to work straight and I didn't have any issues at all. I did around the day, the next day was fine. My wife had a bit of a temperature for a day. What government is, and the patient information leaflet, which has been released by all these, suggests that it will be myalgia, which has been seen in around 60% of the patients, and arm pain in around 60% of the patients. Only very few have had fever or anything else, any other systemic response. Major side effects, extremely rare, extremely rare. So that's something which people need to be reassured of, that the side effects profile is quite low, and what you are expecting to get can be from even a flu jab, like a pain in the arm, or a bit of a temperature, as Dr. Sandhu mentioned. You can get it from that or any other vaccine as well. So there's not more than anything else at all. So I was just reading a question: can antibodies from an infected person be given to healthy people? Apparently happening, and that's the convalescent plasma, which we just talked about. There is no other way to extract antibodies from somebody as such.
Thank you. I think that concludes most of the questions. Actually, I see one more, and it's come twice, so we will go through that. It's someone that wanted to inquire that their father has a couple of comorbidities. So they've got heart issues and diabetes, and incidentally, they've had an epidural into their back, which is, of course, steroid, which typically would reduce your immunity, but it's in the back, so very little absorption. Harman, could you comment if heart disease, diabetes, or an epidural steroid injection would be a contraindication to having the vaccine?
Absolutely not. No, absolutely not. I think having heart disease and hypertension and diabetes is a more reason for them to have the vaccine done, because they are at high risk. And having a steroid injection at the back with a low absorption and one dose is not going to decrease their immunity. It will need a long-term steroid use to actually suppress that much of immunity. And they absolutely should get it as soon as possible, whenever the time comes.
And just to add to that, and to point out again, these are not live vaccines. So even if your immune system is weakened, you are not contraindicated. And what we're doing at the process at the moment with all of our HIV patients is actually trying to find the ones with the weakest immune systems to get them vaccinated, because we're more worried about them catching COVID.
That's absolutely right. And then lastly, anyone that has any concerns about being able to access the vaccine, is there anything that people need to do, Harman? Do they need to express an interest somewhere? Do they need to contact their GP, ensure they're on a list? Or are we going to assume that this automatically happens as the government rolls it out?
So before this vaccine program rolled out, all the general practitioners were asked to create a list. And this was right in wave one. They were asked to create a list of people who they thought required shielding. They were asked to create a list of people who were at high risk and who are at low risk. So those lists were there even before the vaccines came out. And when the vaccine came out, that's when people asked, the GPs were asked to actually start booking those patients on as a basis of priority, with the groups 1 to 6, which were created by the government, to get vaccines. So if your GP would have your name on their list, and they will ask you or send you a link to book in your appointment for the vaccine. You do not need to have NHS number in hand to book your appointment. So the GPs can provide vaccination centers the NHS numbers directly. So you can book in an appointment. You don't need to do anything. Whenever your turn is, you will be contacted directly via phone or text message or email by the vaccination hub or your GPs. So that's how it is being rolled out. In Southall and Ealing, there are 2 community centers, Dominion Center in Southall and Town Hall in Ealing, which are running this. And you can have vaccine appointment from either of them. It is not necessary that if you're living in Southall postcode, you can't get vaccine in Ealing, or you can't get vaccine in Hillingdon or Hounslow. You can have, you may have to travel a little bit, but that's just because your GP has actually prioritized you for vaccine, and you're getting a link to send across wherever the appointments are coming up. So there's a question, quite an interesting question here, which says Southall has highest rate of COVID. Can you comment on this? And I think the data which came out yesterday, unfortunately, Ealing Borough is top in London for last 2 weeks now with the highest rate of COVID infection. Last week, it was 632 per 100,000 population in Ealing Borough. And I think that is down to various reasons. And I will call it multifactorial. One of them is the fact that a lot of our population is in face-to-face working role to maintain their daily livelihood. And they unfortunately cannot stay at home, are not being supported that much that they can feed their family without working. So that is one of the things. The second is house sharing, as we discussed. A little bit about the joint families, but also it is down to individual responsibility, which people tend not to take in certain areas. And there is a lot of, if you go around Southall Broadway, I still see people without wearing masks, no social isolation, and walking around quite as everything was fine and normal. And that probably is wrong. I spoke to a few of them who I knew, and that why would you do that? And one of the things which came up was, oh, have you seen what's happening in India? Nobody died, nobody had COVID, it's just not there, it's just a hoax. And that came up quite a few times. And I keep saying that if you talk to anyone in India, everybody knows of someone who died, and they died of a heart attack, as they call it, because nobody is calling it COVID in India. And if it doesn't exist in news or media, doesn't mean that the disease doesn't exist. The disease still exists, but it's just been wiped out from the media. That's what it is. And that's down to personal media coverage or whatever the rules and regulations are. But what we are seeing is the harsh reality, the bitter reality of COVID in hospitals, where we are seeing young people die in front of our eyes, and we feel helpless at that point. And it is extremely psychologically distressing to see that sight, having a young person die in front of you and you're not able to do anything. And it makes me angry when I see people not following the rules and disbelieving in COVID, that it doesn't exist. So please, I would humbly request to everybody that we all must follow the rules. Safe social distancing, masks and hand washing.
Thank you. No, that's a very important point. Did you want to conclude on anything now, Gurjinder, as well?
No, I just wanted to repeat that point that Harman made, because I think sometimes what hurts us within the NHS is where we see the extremes of people who are denying that this is happening. And if they are denying it is happening, then they are denying what we are witnessing day in, day out. And what's been tough, I moved from Ealing to Kings, and there we've got quite a large Afro-Caribbean population, and I could see how this was impacting families, and probably families who just wanted to get together for Christmas and didn't know how much harm that would cause. And watching an elderly man and woman where the wife is supporting the husband to try to keep his mask on, but effectively watching him die, and then knowing that their son has died, but we've not been able to tell them that news because they're both just fighting for their own lives. This is impacting people, it's impacting families, it's real, it's happening, we're witnessing it day in, day out. And I really do worry about how social media and just general media is managing to portray this image that this is made up, that this is created, and it's not.
Absolutely. And I hope that all our listeners today have heard, both you and Harman working at the front line, and your stories that you've shared with us, I think clearly illustrate that this continues to be a burden globally. And it's in everyone's grasp to do something to take those precautions and, most of all, get the vaccine.
So just to add on to that, I was just reading the comments again. I think the last comment was about the farmers really and the Golden Temple worshippers walking around. It does not help, and I totally agree with that. And I think looking at the Golden Temple every day made me feel scared for my own family back in India, and my parents back in India, who I've been trying to tell them that they have to wear masks everywhere they go. And probably they said that sometimes they're the only ones who are wearing masks when they go out. And that was one of the biggest reasons why I pushed them that they must get the vaccine as soon as they can, because that is the only way to keep our families and friends protected, and vaccination is the answer. Somebody has put in a comment about phase 4 trial and long-term side effects, and I think we just had quite an interesting information from Dr. Sandhu saying that the mRNA vaccine does not stay in the body for more than 3 days. So it is not like a drug which is going to cause a long-term side effect. This vaccine stays in body only for 3 days. So we are certainly not in a phase 4 trial or phase 5 trial or whatever somebody wants to call it. But what we are here is it's just a small dose produces a immune response in the body to fight against or produce defenses against the coronavirus. Not that it is going to stay in body, protecting yourself for the next 20 years.
Absolutely. Thank you. Well said. And thank you to both of you. I hope we've covered everyone's questions. Is there anything else anyone wanted to add? Otherwise, we might conclude because we've been running for an hour now.
Thank you. Thank you all. I think, yeah. And Pooja, I thank you for hosting this workshop, a community workshop for us. on this COVID-19 vaccine. Thank you to Dr. Harmandeep Singh and Dr. Gurjinder Singh Sandhu. What I just like to say, just quote some figures. As of 29th of January 2021, according to Bloomberg, more than 90.8 million doses in 62 countries have been administered. The latest average daily rate of vaccination is roughly 4.34 million doses worldwide. As of 28th of January, 7.8 million vaccines have been people have been vaccinated in UK. If we take an average of 400,000 doses every day in UK, by the close of today, will be just shade below 9 million people who would have been vaccinated. So far, no government in the world has made the vaccine to be mandatory, but Matt Hancock has not ruled out anything. So far, no death has been reported due to vaccination, either during the trial or actual vaccination worldwide. So thank you all. I'm really impressed the way you have explained in very simple terms, free from jargons. At the time of this pandemic, our country needs all of us to get together. You're all familiar with the victory sign, which is shown like that. And I say the victory sign is to be replaced. V for vaccination, which leads us to victory. Thank you all, and God bless you. Thank you.
Brilliant. Thank you.
Thank you.